Retroviruses HIV. These are RNA viruses that belongs to the family Retroviridae. The members of this family possesses a reverse transcriptase RNA directed DNA polymerase. Enzymes which prepares a DNA copy of RNA genome is in host cells. The presence of enzyme reverse transcriptase is a characteristic feature. Classification: the family Retroviridae has been divided into two subfamily Ortho-Retroviridae, Virinae, and Spuma retrovirinae. The most important retrovirus is a human immunodeficiency viruses HIV1 and 2 belongs to the genus lentiviruses. Human immunodeficiency viruses HIV is a spherical envelope viruses about 90 to 120 nanometer in diameter. It contains two identical copies of single standard positive sense RNA genome. It is associated with the viral RNA in the reverse transcriptase enzymes. The virus core is surrounded by a nucleocapsid composed of a protein. The virus contains a lipoprotein envelope. The major virus coded envelope glycoprotein or projecting spikes on the surface and the anchoring transmembrane pedicles. These spikes binds to the CD4 receptors on susceptible host cells. Viral genome and antigen. The HIV genome contains three structural genomes: GAP, POL, GAG, POL, ENV. The characteristics of all retroviruses: the five non-structural genes TAT, REV, NEF, VIF, VPR are present in both HIV and HIV1 and HIV2. Other than these, HIV1 and contains VPU and HIV2 has a VPX. The product of these genes, both structural and non-structural, act as an antigen. The infected person's serum contains an antibody to this antigen. The detection of this antigen and antibody is of great importance in the diagnosis and prognosis of HIV infection. Antigenic variations. HIV undergoes frequent antigenic variations of core and envelope antigen. The two distinct antigenic types of HIV has been identified: HIV1 and HIV2. The antigenic variation occurs within both HIV1 and HIV2. HIV1 represents the original isolate from America, Europe, and Western countries, whereas HIV2 represents isolate from Western Africa. HIV1 strains have been classified into 10 subtypes A to J. The subtype C is the most prevalent in India and China. Cell tropism. HIV infects the cell expressing at their surface the CD4 antigen, which is the receptor for the viruses. The CD4 helper inducer lymphocyte are principally involved in HIV infection, but other human cells expressing CD4 are also susceptible. The infected CD4 expressed a high level of GP120 on the surface. The T4 lymphocytes are principally involved in HIV infection, but other human cells express CD4 also susceptible. The infected CD4 express a high level of G120 on the surface. The G120 on the surface of the infected cell leads to the fusion of these cells with the CD4 proteins of uninfected neighbor cells. The lysis of a fused cell finally occurs, resulting in the depletion of a large number of uninfected cells from the circulation. HIV resistance. HIV is inactivated by the treatment of 35% isoprazole alcohol, 70% ethanol, 0.5% lysol, 2% freshly prepared glutaraldehyde, and 0.5% sodium hypochlorite, and 3% hydrogen peroxide for treatment of contaminated medical instrument, and 2% of glutaraldehyde solution is useful. Mode of transmission: sexual contact, parenteral transmission, perinatal transmission. This is the acquired immunodeficiency syndrome. Incubation period of AIDS varies from 1 to 14 years with an average of 6 years. The clinical responses to HIV in adult are shown. Most of the patients with HIV disease dies of infections other than HIV. Example: opportunistic infection and malignancies. Exposure to HIV: no infection, acute infection, persistent generalized lymphadenopathy, PGL, asymptomatically, A or C, and AIDS, and neurological disease. Laboratory diagnosis. Laboratory diagnosis of HIV infection includes a specific test for HIV and a test for immunodeficiency. Specific test for HIV infection: anti-detection P24 antigen, virus isolation, detection of viral nucleic acid, antibody detection. Non-specific test: total and differential leukocyte count, T lymphocyte subset assay, IgG and IgA level, skin test for CMI, the test for opportunistic infection and tumor. The specific test for HIV infections: antigen detection. The P24 antigen is the earliest virus marker to appear in the blood. The P24 antigen capture assay ELISA can be used for detection of this antigen. Virus isolation for diagnosis: virus is not routinely isolated. The patient's lymphocytes are co-cultivated with uninfected human lymphocytes in the presence of interleukin 2. The viral replication can be detected by demonstration of a reverse transcriptase assay and presence of viral antigen. Detection of viral nucleic acid. The viral nucleic acid can be detected by polymerase chain reaction. It is also useful for the diagnosis in window period. Antibody detection. The demonstration of antibody is the simplest and most commonly employed technique for diagnosis. It may take several weeks to months for antibody to appear after infections. HIV infection patient remains negative for antibody during the window period when initial virus replicate takes place for about 2 to 3 weeks. The diagnosis of HIV infection is made by detecting serum antibody to viral protein, both core P25 or envelope GP120, GP41. There are two types of serological tests: screening and supplement. Screening test, ELISA test. It is highly sensitive and specific test. It is an extremely good screening test, and most laboratory uses a commercial ELISA kit that contains both HIV and HIV1 and HIV2. Saliva is acceptable alternative for serum for antibody testing by ELISA. Rapid test. These tests have less than 30 minutes and do not require expensive requirements. A simple test. It takes 1 to 2 hours and do not require expensive equipment. Supplement test. Western blot technique. In this test, supplemental test. In this test, HIV proteins are separated by polyacrylamide gel ultrafiltration. The separated proteins are plotted on the strip of nitrocellulose paper. These strips are reacted with the test serum. The antibody to HIV protein, if present in test serum, combined with the fragments of HIV. The strips are washed and reacted with the enzyme conjugate and antibody human globulin. The suitable substrate is then added with the product's colored band. The position of a colored band on the strip indicates the fragments of antigen with which antibody have reacted. The positive reactions with the protein representing the three genes GAG, POL, ENV is conclusive evidence of HIV infection. The test is also considered positive if it shows band against the at least two following proteins: P24, GP41, GP120, 60. The positive result is any one screening test may not accept without confirmation. It was the practice to use Western blot test for confirmation. The practice now is performed either to two different types of ELISA or an ELISA with any of the rapid test. The serum positive in both tests is considered positive. Indirect fluorescence test. Positive test, apple green fluorescent appears when examined under fluorescent microscope. Strategies for HIV testing in India. Strategy 1. The serum is subjected once to E or S test, and if positive, the sample is taken as HIV infected, and if negative, the serum is considered to be free of HIV. This strategy is used for ensuring donation safety, blood organ tissue. For this purposes, a high sensitive and very reliable test kits must be used. Strategy 2. The serum sample is considered negative if the first ERS test report but if positive, it is retested with the second ERS test based on different antigen preparation and or different test principle. If found positive or second ERS test also, it is reported as positive, otherwise as negative. This strategy is used for HIV surveillance. Strategy 2. The serum sample is processed as in strategy 2A, but the sample positive first ERS test and negative with the second test is subjected to the third ERS. If the third test is positive, sample is considered to be equivocal. Such person should be retested after 2 to 4 weeks. If the third test is negative, it is reported as negative. 2 to 3 different ERS tests based on different antigen preparation and or different test principle are used. If first two tests are positive, a positive report can be given to the patient after post-test counseling. The strategy to be is used for diagnosis of individual with a symptom suggestive of a AIDS clinically. Strategy 3, it is similar to the strategy 2A with added confirmation by third ERS test. The third test should be again be based on different antigen preparations or a test principle. A serum testing positive of on all three ERS tests is reported positive. A serum sample negative in third ERS is considered equivocal. Such person should be retested after the third test. If this specimen also provide an equivocal result, the individual is considered to be negative for HIV antibody. This strategy is used for diagnosis of HIV infection in asymptomatic individual. The first test selected for any of these strategies should be of highest sensitivity, and second and third test should be of highest specificity to eliminate any chances of false positive result. Applications of the serological test. The serological test for HIV infections are applied in the following situations: screening, seroepidemiology, diagnosis, and prognosis. Prevention. The use of condoms can prevent the transmission of virus through sexual route. The contaminated syringe or needle should not be shared. All blood and blood products are to be screened for HIV. No effective vaccine has yet been found. Antiretroviral therapy. The specific treatment with antiretroviral drugs is the mainstay in the management of HIV infections. Highly active antiretroviral therapy, HAA or is effective in inhibition of HIV replication in most of the HIV infected individuals. Post-exposure prophylaxis. Exposure to blood, body fluid, other potentially infected materials, or an instrument contaminated with one of these materials may lead to risk of acquiring HIV infection. The risk of infection varies with the type of exposure and other factors. The most exposure do not result in infection. Health workers are normally at a very low risk of acquiring infections during the management of infected patients. Following exposure, post-exposure prophylaxis may be required depending upon the category of exposure and HIV status of exposure source. Basic post-exposure prophylaxis regimen consists of two drugs combination, while expanded post-exposure prophylaxis regimen is a combination of three drugs: zidovudine 300 mg BD and lamivudine 150 mg BD are used in basic two drug regimen. In expanded three drug post-exposure prophylaxis regimen, a protease inhibitor is added to this combination of the drugs. Among protease inhibitor, the lopinavir 400 mg BD or 800 mg OD or ritonavir 100 mg BD or 200 mg OD are prepared as the drug. To be effective, these drugs must be started within first 72 hours and ideally within 2 hours. The post-exposure prophylaxis should be continued for a period of 4 weeks. Both risk of infection and possible side effects, the effect of antiretroviral drugs should be carefully considered when deciding to start post-exposure prophylaxis. Beside post-exposure prophylaxis, injury site on the wound should be thoroughly washed with soap and water. Antiseptic may also be used. Exposed patient should have post-exposure prophylaxis HIV testing at 3 months and 6 months. If the test at 6 months is negative, no further testing is required.